Congress. And let me now introduce my dear friend and lovely professor, Professor Wayne Massey, Duke University, USA. He's going to present mononeuropathy in pregnancy. We are all waiting for you, dear Professor.
Thank you very much. Good morning. I'm honored to be here with you in Egypt and appreciate so much being asked. My wife and I both enjoy being here and will continue to enjoy it for the next few days. I'm going to talk about compression neuropathies, but include particularly the ones that we do see in pregnancy, and I'll emphasize that as we go along. I want to realize that we use the word compression neuropathy because that's what I think is difficult, but not entrap. You just call it entrap neuropathy. There are a few entrapments, maybe carpal tunnel median nerve, as you could say, is entrapment. Inguinal canal, the lateral femoral cutaneous nerve of the thigh can be called entrapment. But most of these are compressions that we get from doing things by leaning on our elbow or crossing our legs and that sort of thing. I'd like to emphasize a few of us how they emphasize some associated with pregnancy, of course, with the initial title. Why are all compressions not the same? Well, there's various things that will affect it. Certainly, at the bottom, systemic predisposition. For example, people with diabetes are at risk to common mononeuropathies. If you have diabetes and you sit for a long time with your legs crossed, then that's different. But also, genetics have a factor. Individual variations have a factor. And axon location. Remember, you like to say that if the axon is one location approximately, it'll be in the same location in the nerve distally, and that's not true. The axons swing back and forth through the nerves, so it can be different at different locations, even millimeters apart. The other thing to emphasize that since we're talking today about emphasize some occur in pregnancy is the aspect of gender does affect our risk in certain neuropathies. The most common one, I think, is crossing the legs in the perineal palsy. The fact is, things like that can affect, and how often you lean on your elbows when you're in meetings and so forth, and are you predisposed? That sort of thing needs to be considered when you see these people. I want to mention, and I'll go through fairly quickly because of time, but talk briefly about median neuropathies, ulnar neuropathies, emphasize perineal femoral neuropathies. Tibial, just briefly mention it. Sciatic piriformis syndrome that we see, but we also see it in other locations, and I want to particularly show a few slides with the notalgia parasitica on the back with multifidus muscle, T2 through T7. I'm sorry, T2 through T6. And then we'll also talk about some other things that are really hard, like brachial plexus, and are hard to diagnose. The key here, as all of us in the audience I'm sure know, I'm not saying anything unique, is anatomy. We have to know our anatomy. And neurologists and, we have to know our peripheral anatomy or this doesn't make sense or we can't do this adequately. And we alluded to there's different forms of compression. Location makes a difference, location of the nerve. For example, we can see the ulnar neuropathy. We almost always think of it in here at the Lacunon groove, And it is there in people who, let's say, young women who fall and fracture this area when they're young can have this particularly narrow bony canal that would predispose them to it. But also other internal aspects. For example, people with cancer at increased risk. The ones that we think of most often are the patients with diabetes, because they clearly have multiple mononeuropathies at times, or they can have mononeuropathy multiplex. And of course, that's hard. You have to differentiate between the two of those because of prognosis. And then, of course, there is some association with familial PMP22 and other risk things. And we just heard about GBS and CIDP, and patients who have had GBS are probably forever at some risk, increased risk of compression neuropathies. Upper extremity, I'm going to mention a few of these. Just everybody in the audience knows these probably, but we're going to just try to review a couple things about that. And then lower extremity, we'll talk about primarily the femoral nerve and perineal nerve. Perineal nerve is very common. Upper extremity, median nerve, I think, is most common, but lower extremity perineal is the most common one we see. If you can exclude the sciatica that occurs from actually lesions inside the spine. So median neuropathy, you have to know the anatomy, and then of course we all, when you see the patients, these are the patients who have numbness in their hands, often at night, often more prominent in the dominant hand than in the non-dominant, and also can have some weakness, and that's what we'll be looking for. You have to know this anatomy. We talk about it underneath the transverse carpal ligament, which is in the palm, not in the wrist, but even though we see it, some situations in the wrist with enlargement of the nerve is probably due to entrapment. As the nerve goes through the transverse carpal ligament, and there's other things in there, like the tendons and so forth. Now, in this particular situation, when you see people who come in and tell you this, show you this, and you find sensory in this distribution, that's median nerve. That's pretty easy. It's just not always that easy, but you can look for examination when you look at the abductor pollicis brevis and the opponent's pollicis. Both are very helpful when they're weak. They can confirm that, hey, this is my suspicion. And then when you look close in many patients, you find that they're actually in the abductor pollicis brevis. You'd like to find this long before it gets to this stage, because we can treat this. We can do something about, as we all know, we can do lots of things to try to help this situation. The one that we emphasize a lot is carpal tunnel syndrome associated with pregnancy. The question is, why do young women get that during pregnancy? And there are lots of reasons. Some people say it's just the edema, the swelling inside the canal. That's not always been evident, but there are other possibilities that we have to think about. In carpal tunnel syndrome in pregnancy, it usually comes on in the third trimester. That would suggest that it's edema. If it comes on earlier than that, then it may be that they had a carpal tunnel syndrome anyway, and before. I do not think it's wise, in my opinion, to operate on carpal tunnel syndrome when it came on in the third month of pregnancy. You wait till after they get it over, and if they're months out, they still have the symptoms, then you might have to consider other options that are, reasonably common and safe, but obviously there are also medication trials that can be done and so forth. And of course, sometimes, more recently, the ultrasound in this location helps us with the diagnosis. Ulnar neuropathy, again, the anatomy is what you need to emphasize. We often see it at the olecranon groove, but we do see ulnar neuropathy more distally in the hand, in the pulse under as the deep branch goes underneath the uh, ligament, and that is an option to worry about. But the symptoms would be different in that particular situation. When you see atrophy of the interossei, and it is extensive and is only the ulnar nerve, in other words, the abductor pollicis brevis and opponents are normal, and this is very weak in the first CIO or the small muscles, then you know that this is ulnar neuropathy. And again, you can have atrophy of the first CIO. You'd like to find it before it gets this bad so we can do something about the treatment. Localizing it electromyographically is sometimes difficult. Nerve conduction studies, sometimes it's hard to say whether it's pre-canal, in the canal, or post-canal, but it's real important because that helps determine how much where we go to try to treat it. Real important in treatment. Of course, you can add to that by doing ultrasound and seeing it if it's in the canal, that's where you know the problem is. Radial nerve, I'm just going to mention, is not common in pregnancy, neither is ulnar that necessarily, but it does occur occasionally. This, of course, is usually we think of it as from some falling asleep over the park bench kind of thing, or maybe the honeymoon where the wife sleeps on there during the honeymoon, but that's the only time you see that is the honeymoon. But anyway, they'll present in this situation. You again know the anatomy of the radial nerve in the proximal to the elbow, mid shaft, and it can be caused by many things. We've alluded to the most common one written about, but in the military, you see it from people diving out of airplanes. In our area, we have a lot of military bases, and parachuting is a major thing that people learn, and that's why I see more due to the person wrapping around the upper radial nerve. Presenting with a wrist drop, important here in your examination, don't forget that you can't examine the ulnar nerve very well in this position. You have to dorsiflex the wrist before you can really see whether there's weakness beyond the radial nerve. Again, ultrasound can help you. Don't forget, there is this syndrome of choralgia paresthetica, a sensory loss. This is my experience, very common in pregnancy. It's common in people who wear tight bands around their wrist. Very common in people who have had handcuffs put on. And in London, I understand the most common cause is when people are hit by the police with a restrictor. This would be something that we can help electrically know what is going on. And it can look differently. Both these are diabetic patients. Brachioplexopathy, I'm just going to mention how important the anatomy is. It is an extensive anatomy. Obviously, you can have a plexopathy in various forms, even associated with cancer involving here, of course, and then the other was radiation. But we do have plenty of cases of idiopathic plexopathy that can be different presentations. And electromyography is what really helps us determine what might be the prognosis and added way to work up the patient. I'm going to just, you can see that a very common one is when they get scapular winging, and that would be, this is a very important emphasis to my staff and residents. You know, you need to take the patient's shirt off in order to see this kind of thing. You're not going to see it if you don't undress them and try to look all over. This one happens to have the plexopathy on the left side, but on the right side has notalgia paresthetica that he's had for many, many years. And this was a diver, a scuba diver that we take care of quite a bit of. Again, it can have different muscles that are involved when the plexopathy can be from different locations. neuropathy, lower extremity. Remember, the femoral nerve comes out through the inguinal canal. The Again, anatomy is where you determine where this could be. There's multiple locations. Um, the etiology is very interesting. We always worry about it, cancer sitting down in that location, but probably the most common cause is again diabetes. Getting diabetic amyotrophy and differentiation with that is extremely important. Perineal neuropathy we see the most common, and this we do see with pregnancy. But again, it's crossing the legs and doing the perineal nerve as it comes around the fibular head. It was been called in different things in different locations. I guess in mid-America, they call it hog bite palsy because they raise a lot of hogs and they bite it at that location. We have a contest in our area every year to see how long people can sit on their haunches. Let me just show you. Now you say, well, you know that we all do that some a little bit. And catchers, baseball, they do it a whole lot. And I'm sure lots of other situations. But the contests that we see have once a year is people sitting in that for long periods. And I don't know why they have this contest, but it's the winner that I saw most recently was 26 hours. He sat down like that for 26 hours and he won the contest, but he had perineal palsy bilaterally. Obviously, the foot drop and sensory loss in the anterior lateral lower leg is important. The dorsum of the foot. Don't forget that the perineal nerve splits at the fibular head, and so we can see a sensory involvement of the anterior leg, with only motor being the peroneus longus and brevis, everting the foot, or we can see a motor where a person has a foot drop, only has sensory coming out through the dorsum of the foot between the first and second toes. So it can be different kinds, and this is where not only the electrical study can help us tell us exactly more likely which would be where a location. And of course, you can get atrophy of the anterior compartment if it's alone. This is a dimple sign that's very common in perineal neuropathy called Carney's. It's an eponym, dimple sign, and it can be helpful. It's really common, particularly in people who do this chronic leg crossing. Almost all of them have this. Sciatic neuropathy, we always worry about it being in the back, but when in fact there are certain situations where it occurs in the buttocks area. Piriformis syndrome is one that's been described, but also sometimes in prolonged surgery. People who are having cardiac surgery for several hours, if they don't have the right protection, can develop sciatic involvement. And of course, you have to again know the anatomy of what the distribution is. This is probably the most common one in the lower extremity, in my experience, is lateral femoral cutaneous nerve of the thigh. The anatomy, of course, we all know where it comes off L2-3, mostly proximally, but it comes through the inguinal canal. Wartenberg described this very nicely and found that there was at least 5 different places that the nerve could be entrapped. This drawing is inaccurate in the sense that it only shows the supply to the anterolateral thigh, which is most commonly what we see. But the nerve also supplies part of the buttocks. So occasionally you see it going around on the buttocks. This is where I emphasize drawing on the patient. This, if you draw on the patient with pen, and there's nothing else that does this. An L4 radiculopathy doesn't look like this. This is lateral femoral cutaneous neuropathy, and it can look different ways. It doesn't have to all look the same. This, where the cross marks is very hyperesthetic, but anesthetic, or relatively anesthetic, more proximal than that. Again, another example of it, in a young woman, this occurred during her pregnancy. I'm not sure that there was any relationship to her pregnancy. And then, of course, it can be here as another example. It can look quite different. I want to go back, and before I go to the next one, one that you do see fairly common that occurs, as far as I can tell, from the pregnancy itself, is when when a young woman gets obturator neuropathy. And it's usually, after my experience, and I've seen quite a few of them, it's usually when they're delivered vaginally, bottom first, and not head, but they can be either way. The thing to keep in mind is that they are very painful, and you can't get an adequate examination for a few hours. But when you do get the examination, you can find that they're quite weak in the adductors of the leg. Now, the important thing here, in my opinion, is to watch these young women for a while. And for a while, I mean several weeks, because it often goes away. And sometimes it goes away, in a few days. So for them to have their new baby, and you send them down to electromyography and stick a needle in them, at 5 days, it's probably not worth it. Maybe worth it at 3 weeks if they're still a lot of pain and they're weak. Then we might want to get a study to help us. Is that what we're dealing with? Truncal mononeuropathy, I want to mention, does occur in pregnancy, as you can see on the right. It can be quite uncomfortable for these women. The prognosis is usually pretty good. So again, this one I'm showing here, this was her third pregnancy, and she didn't have it the first pregnancy. She did the second pregnancy, went away totally after delivery. What is this due to? Most likely it's some kind of pressure stretch of some of the nerves in the back. Is it worth needling the back to prove or disprove it? Not if it's very classical, and that's again where I think drawing on the patient is very important. The one on the left is a diabetic. Diabetics not infrequently can have a neuropathy of the chest wall. It gets very complicated. It's thinking whether almost all of these that I've seen with this, they've had GI workup first, because that's what people are wondering that it's due to. This is probably the most important one I can mention today. Most important one I just want to mention is facial mononeuropathies. The most important one is here on the left, mental nerve neuropathy, because those situations, they have cancer. Almost every patient who has mental neuropathy have a cancer of some type, and often it's lymphoma, and there is an appropriate workup. Sorry I went so fast and so long.
Thanks, Professor Dr. Wayne ماسي and welcome Egypt. طبعا أنا بشكر السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. بشكر اللجنة المنظمة
أشكر الجمعية على المؤتمر ودكتورة سالي ودكتور حاتم وكل اللجنة المنظمة، وطبعا نظرا للانستراكشنز الشديدة اللهجة اللي أنا متلقياها قبل ما أجي، فأنا يعني هبقى سريعة بقدر الإمكان عشان التوبيك النهارده او اللي هتكلم عليه الار تي ام اس في اللور urinary tract dysfunction in MS patients. MS is a chronic autoimmune degenerative disease في الcentral nervous system. lower urinary tract symptoms is reported في ال first 8 years of diagnosis. average في الأول 8 سنين العيانين بيبقوا presented ب urinary tract symptoms. ممكن تبقى كمان هي ال first initial MS manifestations. Due to the progressive nature of the MS, the prevalence of lower urinary tract dysfunction ممكن تبقى up to 100% within the first 10 years of presentation, which is affect the quality of life for sure. Urination is a reflex, a sacral reflex, ولكن supracranial control, of course, to start or inhibit this reflex. Abnormality type cuts on the improvement of the patient's symptoms for better life, quality of life. Secondary, to preserve, of course, the upper urinary tract having a various kind of line of treatment, modifying drugs, complexity of the disease course, and the clinical symptoms of the MS. Of course, require personalized treatment for the disease, including non-pharmacological treatment, and of course, transcranial magnetic stimulation is a painless, non-invasive brain stimulation technique, which has been widely used in different neurological diseases. What can we do in TMS? The short-lasting magnetic field is applied to the brain or whatever the site of stimulation to the coil, and induces a relatively focal electrical field in the subject on the subjacent cortex. This electrical field causes either depolarization or hyperpolarization, subsequent voltage-gated ion channel brain, which lead to modification of neuronal activation threshold. This is how it works. Applying the coil بيحاول magnetic electrical stimulation كأني بالظبط بعمل electrical stimulation which is painless. TMS techniques such valuables كتير affect how it can affect the brain, complexity بتاعته through the cortical على الcortical morphology اللي انا بعمل عليه application للstimulation, conductivity design بتاعت الكويل وشكل الكويل, of course the frequency of stimulation. low frequency أقل من 1 Hz induces emission, and high frequency induces stimulation to increase the cortical brain excitability. repetitive, it is a multiple or first application of trains بقى, يعني انا مش بدي just one train ولكن بدي multiple trains. This repetition build up effect that might enhance the therapeutic benefits gained من السنجل application. اللي بعد ما بعمل single pulse بعمل multiple trains which is update or enhance neuroplasticity and generation of multiple actions, and in order to produce this effect in a kind of way وان هو يستنى شويه فبنعمل several trains for several sessions. عشان كده الناس لما بعمل تبقى شغاله just one session ولكن بتبقى repetitive days, frequent days. Alternatively use للRTMS عشان to use high frequency short duration stimulation ممكن ادي frequency up to 50 Hz, والF دي ايه approved TMS management او therapy يعني لمالتيبل forms من الابنورمال neurological abnormalities, واشهر حاجه فيهم طبعا الدبرشن. في المودز السنجل والريبيتيتيف والانتر كونتينوس او رابتد او intermittent. طيب magnetic stimulation في اليورينري dysfunction الحقيقه ما كانش فيه literature كتير اشتغلت عليه في اليورينري dysfunction او اشتغلت في الام اس بالذات او اشتغلت عليه في حاجات زي السباينال كورد انجز او ستريس انكومبتنس. الابلكيشن هاو تو ابلاي الكورتكس ايذر ابلايد على الموتور اريا او على البلفيك فلور, او في بعض الناس او بعض البيبرز استخدمت سيكرال ستيميوليشن ديفرنت بقى في الارج انكومبتنس والديتروزر اوفر اكتيفيتي والنكتورنال انيوريسيس. دي some papers يعني دي اشتغلوا على الابلاي السبلمنتري موتور اريا ابلكيشن للعيانين اللي عندهم بلفيك فلور ماسل سكين سندروم, ولقوا ان هو stimulation للسكر stimulation with high frequency بتريليف البين. يمكن دي البيبر الوحيده قبل ما نشتغل كنا لقيناها انها اشتغلت على الموتور كورتكس بهاي فريكونسي. عندهم العيانين اللي عندهم lower urinary tract dysfunction. سيكرال روت في الدكتور الدكتوره ايمان طبعا اشتغلت في حاجات كتير، ودي برضه طلعت ان هو ممكن لو احنا عملنا سيكرال ستيشن هاي فريكونسي في العيانين دول benefits. احنا شغلتنا كنا بنشتغل على الحقيقه في العيانين ام اس كنترول السيكرال كورتيكال جروب A having the trouser overactivity and group B to assess the post-void residual urine, urodynamic evaluation, maximal cystometric capacity, maximal flow rate with the trouser pressure, وسايكومتريك analysis for quality of life questionnaire، وتعمل لهم assessment for تعمل لهم repetitive stimulation for 2 weeks، و after the 2 weeks from 1 to 7 days تعمل لهم reassessment. اللي احنا اشتغلنا الفريكونسيز اللي احنا عملناها 5 هرتز 80% من موتور threshold 20 trains 50 stimuli، وزي ما قلنا 5 days for 2 weeks، ودولت either applied على الكورتيكال area or applied على السيكرال the same manifestation. عشان يعني هجيت تو ذا بوينت على طول. العيانين الجروب اوف اوفر اكتيف بلادر الحقيقه ما حصلهمش اي improvement either على الكورتيكال stimulation area ولا في السيكرال stimulation، وبالعكس في بعض الاحيان حصل لهم worsening لليورينري symptoms كمان. على عكس الاندر اكتيف بلادر جروب حصل لهم improvement لكل البارامترز اللي احنا عملنا لها اسسمنت قبل وبعد التريتمنت. الثيوري بتاعت الكورتيكال والسيكرال ستيميوليشن اللي حسن العيانين بتوع اندر اكتيف بلادر ان بنهانس الكورتيكال سباينال تراكت اكسايتابيلتي، بتعمل فاسيليتيشن للكونتراكتيليتي بتاعت الديتروزر والسفنكتر ريلاكسيشن، فبتحسن الفويدنج. العيانين اللي عندهم مشكله في الفويدنج. والسيكرال طب ليه بيحصل improvement لما بنعمل سيكرال ستيميوليشن؟ زي بالظبط فكره الاف ويف في الاي ام جي والنيرف كوندكشن، احنا بنعمل ديستال وبيبقى ريفيرد الستيمولس للبروكسيمال اريا. التي ام اس لما بنعمل له سيكرال برضه في ثيوري انه بيعمل ستيميوليشن بروكسيمال ارياز. تاني حاجه ان انا بينهانس ريفلكس بتاع الفويدنج في السيكرال روتس، انا بعمل لها عليها ستيميوليشن. الاند او الكونكلوجن اوف اور results يعني applying 5 repetitive magnetic stimulation over the motor cortex or sacral roots improve lower urinary tract symptoms and urodynamic finding in MS patients with underactive bladder with no reported adverse effects. On the other hand, applying the same protocol didn't show any effectiveness in the management of overactive bladder group. However, it is urodynamic symptoms is common in MS, and so, of course, applying a non-invasive, painless methods which could improve the quality of life of such a group